Good afternoon, everyone, and thank you for attending another Transplant Institute lecture series. My name is Marwan Abuzoud, Director of the Transplant Institute, and it's a pleasure to host today Dr. William Chapman, who is the Director of the Transplant Center at WashU in St. Louis. I was going to say Vanderbilt. So Dr. Chapman is a good friend and is a leader in the transplant community, and many of you may have known about him. He did his medical training at American University of South Carolina, then went on to Vanderbilt where he did surgical training. And he's one of the unique people who went to London to King's College where he trained in hepatobiliary surgery and transplantation during those early times and came back to Vanderbilt and with Dr. Wright Pinson built a remarkable liver transplant program in Vanderbilt. Subsequently, he went down to WashU, which was transitioning a leadership, and he was there as section chief for transplantation, and then became the chief of general surgery and then executive vice chair after that. And during that path, became the Eugene Bricker Chair of Surgery. And Dr. Chapman's tenure at WashU was nothing short of remarkable and history-making. That program became one of the most distinguished programs in the country, a multi-center program that thrived on with every organ and robust research and trained many, many colleagues who are now be very heavily involved with research. We wrote one of the earliest papers on the impacts of ischemia reperfusion and ablation therapies and the impact on systemic inflammatory response. His current interest now is in normothermic regional perfusion, ischemia reperfusion, as well as the impact of ischemia reperfusion on fatty livers and marginal livers. And he's NIH funded. He's got a lab and many people making excellent productive research and has had over 300 published papers as well. He's the immediate past president of the American Society of Transplant Surgeons, a very active time during our society, and he was involved in many other societies, the American College, the American Board of Surgery, and the American Hepatobiliary Pancreatic Association, ESPBA for short, where he was also the president about 10 years ago, right, Will? Around that time. He serves on many editorial boards, and I'm not sure how he makes all that time. I think he works on a different clock. But today we asked him to talk about a subject that is going to be impacting all of us one way or another. It has a lot of uncertainties attached to it, but Dr. Chapman was at the table when many of these conversations were being had as the early redesign was beginning. The topic for today is the Organ Procurement and Transplant Network a modernization initiative, what is on the horizon. And thank you, Dr. Chapman.
Thank you, Marwan, for that kind introduction. Now, when Marwan invited me, I said, okay, Marwan, I'd love to come see Henry Ford. I haven't been here before. So it's a very distinguished program. It's been in existence a long time. What do you want me to discuss? And he said, well, I think it would be interesting to hear about what's coming down the pike from a organ allocation standpoint, from a UNOS OPTN standpoint. This is a very difficult topic because, as I'll tell you, we're in the 11th hour, maybe it's 11:30, and we still don't exactly know what's going to happen. But it is an interesting, what I want to talk about is, what I plan to talk about is some of the things that have happened in organ allocation change over the last 7 years that have led to the position where we are today, which is going to be very challenging. Now, what I want to do is talk a little bit about where we have come from, because I think that has a big impact on where things stand today and where the changes that are coming stem from. I have one disclosure. I'm on the board of directors of our local OPO, which I am not really going to talk about in the course of the discussion. Now, in 2000, there was a big effort to look into organ allocation and potential organ allocation changes. And so HRSA and other groups, including the Institute of Medicine, organized really consensus conference efforts to look at organ allocation and came up with what's known as the final rule. So the principles of the final rule, which still hold in place today, are that, and I'll just point out a few of these, not all of them, but that organ allocation should be based on sound medical judgment, that we should achieve the best use of donated organs, that we should avoid organ waste, meaning discards. We should avoid futile transplants, and we should promote patient access with efficient organ placement. And number 8, which is important, is that the organ allocation should not be based on the candidate's place of residence or place of listing, except to the extent required by the above components. So this got a lot of attention, each of these areas, and you had centers that were for major allocation change. We'll talk about what parts of the country that seemed to be, and centers that were not in favor of organ allocation change. And each group, including, our group in the Midwest, would focus on certain ones of those final rule statements as justification for our opinions. So, but the biggest issue that existed for the drives for organ allocation change were areas in the country that had less access or believed they had less access to transplantable deceased donor organs than other areas. And the view has been, especially from those areas, and in large part, we'll show you some data that emphasizes this, it's been a little bit of the Northeast and West Coast programs feeling that their access was much more restricted than the rest of the country. So, the push is that from the final rule standpoint, we shouldn't have geographic disparities, and patients shouldn't have to wait. And similarly, that minorities and economically disadvantaged patients should receive similar equitable access to transplant. This is what has driven the contentious times in organ allocation. So one of the commonly noted points was that in some parts of the country, there was as much as a 12-point MELD score difference, a MELD used for liver allocation, score 7 to 40, that there was as much as 35 in some parts of the country, especially California, compared to 23 in other parts of the country like the Midwest, and that resulted in a 60 percentage point difference in 3-month mortality. Now, that's not completely correct because the areas with high MELD have had much higher use of MELD exception points. So it's not laboratory MELD differences that are this great, but there are differences that are real in West Coast, Northeast compared to other parts of the country. So just to remind everyone, UNOS, United Network for Organ Sharing, has set up 11 regions in the U.S. where I'm in Region 8 here, probably the biggest region in the center of the country. Detroit's in Region 10. This allocation region-based system still exists for administrative purposes, although for allocation purposes, this was being used previously. It's not in use today. We still have this for meeting purposes and for administrative purposes. So efforts start to set up a sharing arrangement that's broader than the prior system, which was based on local first, then regional, then national. So for liver, for example, if you had a high MELD patient, 35 or higher, you shared by the region first. No 35 or higher, which is a sick patient. You start local first, and then if no one local uses a liver, then you go regional, then you go national. So Dori Segev and the group from Hopkins organized the idea of having district maps. So instead, we would have, there were two plans, an 8-district map or a 4-district map. The first proposed was, let's consider an 8-district map. And this went through UNOS committees, got presented, National Consensus Conference, and the idea was, let's go to a district system. And it seemed like for a period of time, we were going to go to this 8-district system. And you can see in the 8-district system, the East Coast was from Georgia all the way to Maine. And then, you know, the Midwest, there's a bigger area for Michigan. That it was not as big an area, but this was put forward, and for a period of time, it seemed this might be the change. UNOS organized a consensus meeting, and I think every person in liver transplant went to that meeting. Marwan, I don't know if you were there, but I was there, and it was very contentious. And so I'll show you a few of the votes. So there were votes, there were presentations of here's what we should do, and then there were votes of how this should go. The 4-district, so the questions were, do you want a 4-district map? Do you want an 8-district map? And you can see the votes there. Or current model, or something else. So the essentially 2/3 of the program leaders in the U.S. said they did not support the district maps. When you looked at the allocation, that allocation should be based on MELD score, and the goal should be make it the same across the country. In other words, a median MELD at transplant, we want to make the same. You can see over 70% of program leaders said, we can't do that. The cost is too high. We're not going to achieve this. The other reservation has been that to say the median MELD is going to be the same across the country, one of the challenges, the aggressiveness of the centers are not the same. In fact, they're quite different. So right across town, you can go to any major metropolitan city, and the organs that will be utilized in an aggressive center are much different. So just using MELD at transplant doesn't tell the whole story. Now, this is actually how the voting went on redistricting. So this was the first major effort to say we're going to equalize allocation. And 8 of the 11 regions voted this down. And you can see Region 10 out of 16 centers that had a vote, 0 were in favor of this. and the same was true for our region. So this was a Region 1, Region 9, that's New England, that's New York. Region 5 is California. This was East Coast, West Coast versus the rest of the country. And after this concept was scrapped. But the idea of changing organ allocation wasn't scrapped. So I was a member of the Liver and Testing Committee at that time. We met either, we would have calls monthly, we would meet quarterly. I think I was on the committee 4 years. It was really contentious. But the Liver and Testing Committee came up with a proposal, and the proposal passed not unanimously, but almost unanimously. And the proposal was, let's go to an incremental change. Let's move towards broader sharing, but let's do it in an incremental way. So instead of MELD 35 being where you go to regional sharing, okay, let's go to MELD 29. Take sicker patients, but not the whole list. And let's put 150 nautical mile circle around the donor, and that would apply to all offers that would be given. But we're going to make it based on lab MELD only. We're not going to have exceptions. We want to have the sickest patients go first, not those with exceptions. And let's look for unintended consequences, and let's try to limit flying and travel. So here's an example. This is if the donors in Georgia. Georgia is a single state OPO like Michigan. And before this idea, only centers in Georgia would be considered, and they're just a few, if a donor came up. So the idea was we can expand that and use this for sicker recipients. And so you can see that if, depending on centers surrounding Georgia, there would be many that would come up for consideration for their sicker patients. We can broaden access for donors in any given area, but it's going to be for any given donor, you're talking about 150 miles, which seemed to the Liver and Testing Committee reasonable. So this is how the map would look for us in Region 8. If you took the whole region, there would be some expansion of potential travel, but we felt like this would be a reasonable consideration. So what about for places like New York? New York would all of a sudden really expand their access. Now, one of the, and I don't want to spend too much time on history lane, this is all old news, but this was very contentious for the Philadelphia programs. So Philadelphia, Penn, and the other programs were very opposed to this idea. And part of their reasoning, whether they're right or not, is New York had the state 152 donors per 100,000 population, the worst performing OPO in the country, with who was complaining about their lack of access to donors. Philadelphia has probably the best performing OPO in the country, and the programs in Pennsylvania would say, we work to build our OPO. New York, the New York OPO had been listed to be decertified twice to say, let's throw out the leadership of the OPO and start over, and that got pulled out. So the contentiousness actually wasn't as much from, say, the Midwest for this new proposal. We supported it as much as it was for the borders of New York, New England, who said, you know, these guys need to fix their own opioid problems, not just say we're going to take organs from the high-performing OPOs. So what about California? The challenge for California is that if you went to this proposal, it didn't help the California program so much because the major programs are on the coast. So a large part of the 150-mile circle is the ocean. And on the other side is the desert. So the only way to really make a difference on the West Coast was to have big circles. So the West Coast was not very much for it. You can see if you look at the maps, there's just not much overlap of a 150-mile circle. But still, the idea was, let's implement this. Let's get some data. Let's see how this works. Let's make incremental steps to broad sharing. There were a lot of points brought up about why we have this allocation issue, high MELD versus low MELD. And this is a paper published by David Goldberg, who's been pretty active in this area. And what David pointed out was that, yes, in the West Coast area, there are higher MELDs that are, if you look at lab MELD, in other words, the true calculated level of somebody's illness severity based on their real MELD score was worse. But if you look in some other areas, especially the Northeast, the calculated MELD, the true MELD, is not that high. In fact, it's lower than some other areas. So we're gonna, but the allocation MELD with the exception points is much higher. So we're gonna take organs from the South, for example, and there will be a net shift to the North and Northeast, which was another challenge, another problem with the concept. So the other idea was, okay, let's introduce large maps. And this shows a 500-mile circle, the acuity circle idea, which is what we have today. At the Liver and Intestine Board of Directors meeting, where this was discussed, the approved Liver and Intestine Committee recommendation was what I mentioned to you before. It had gone through all the UNOS committees, and this was intended to be the 150-mile circle around the donor hospital added for MELD 29 or higher patients based on their true MELD. At the Liver and Intestine Committee meeting, at the Board of Directors meeting, not the Liver and Intestine Committee's approved proposal was the 500-mile acuity circle. At that meeting, the board approved the 500 nautical mile acuity circle. And it was, this had been put in place by the lung transplant, for lung transplantation, partly as a result of a lawsuit filed in New York requesting broader sharing that was, I think it's fair to say, frightening to UNOS that there would be litigation over this. So the lung program had been put in place before, and I think lung was 250 miles. Is that right? I don't know if that's 250 or 500. I think it's 250. But this was even more extreme. 500 mile is the first step. And this was, I would say, a shock to the liver programs and the liver system. There was great concern that this would increase program travel, that how would you manage with the East Coast super region with 50 programs in one circle, that we wouldn't have enough corporate jet fleets to actually be able to satisfy the needs, that there was no mechanism in place for increased cost recovery. And I would say these issues have pretty much, at least in part, been born to be true. We have a cottage industry now of businesses that do recoveries. We have times we can't get a plane to go do a recovery. OPOs are under a lot of challenge, and this has made it difficult. Now, when you look at the actual mortality rate for waitlisted patients, 90-day mortality risk is not what had been put forward in saying you got a MELD of 35 versus a MELD of 23, which you would expect the mortality in the wait list to be much greater, East Coast, West Coast. But in fact, it's pretty much the same across the country. And the mortality rates on the wait list in the South, Deep South or Mid South, are actually worse than the national averages. And why is that? Even though there had been transplants occurring at a lower MELD, lower allocation MELD. And the main reason is the support systems in the rural areas and in the South are not anywhere near like they are in New England or New York or Boston. The Executive Council legal advisor for UNOS privately said, but it was released, when all this discussion and turmoil was underway, that, well, anybody who would live in Alabama, that's their own fault. And that was released. I'm telling you this just because this is how contentious the times were. So what this resulted in is in the fear was the organs are going to move out of areas of higher burden of liver disease, lower overall quality of health care, lower socioeconomic status, that it would lead to closure of centers in rural areas, and that transplant programs do a lot more than just do transplants. They provide end organ failure support that's pretty critical in those areas. Back to the final rule guidance, there's concern about best use of organs, best outcomes, lower discard rates, ensuring that economically disadvantaged receive access, and avoiding waste and futile transplants. Now, since that, when this went in place, so there was the New York legal challenges to put in place broad sharing. I think it was 15 transplant centers collectively filed suit against UNOS and HRSA for unfair introduction of this plan. And just that suit has still been the stay for implementing broad sharing wasn't put in place. So the plan was allowed to go forward. Just recently, within the last 2 months, the judge for that case issued a ruling that that UNOS, and in particular, Brian Shepard, who was the CEO, and Alex Glazier, who was their executive committee attorney, acted in bad faith in carrying out the plan. And this judgment went back to UNOS to say I think they had 90 days to report on that ruling, number one, and number two, whether there would be any consideration for changes or remedies or what do we do next. So I tell you that background just to give a little bit of the view of how contentious this area has been. We implemented the new allocation change. Most medium or big size programs survived, and many actually have done more transplants, but with more costs, more logistics. Our discard rates for liver have increased, and our non-utilization has increased. Kidney discards are up to almost 25%. So the increases that have occurred for some centers, including our own, I think are largely due to centers saying, okay, we're going to have to adapt, but also the total number of donors have gone up. Small centers have had a hard time, and small centers and rural centers have actually generally had reductions in their transplant volume. You can't keep programs going. The expense is too much. So that has all gone on in the background. Congress got involved, and the Senate Finance Committee has held hearings with the OPOs. The OPOs have been under the gun for their performance to increase the number of organ donors, and also they've been under the gun for some of the scrutiny of their practices. CEOs, I mean, this is, I'm sure, not common, but CEOs using the OPO jet to take personal trips. There have been a lot of examples. OPO executive salaries, which are very high, things of that nature. So this has led to pressure on UNOS. Now, those slides that I just showed you are my own. These are some slides that I've gotten from help from the legislative advisors for ASTS. We've been very engaged in trying, from the ASTS side, and trying to figure out where are we going. So, as background, UNOS has been acted as both the private contractor for organ allocation, but has also led the organ procurement and transplantation network. So the original idea was that there would be the OPTN, Transplant Network, who would then oversee UNOS, who is a private contractor, would manage policy, organ allocation, which included the donor net, data management, transportation, and oversight, the whole aspect. But under the direction of HRSA within HHS. In practice, UNOS has been one and the same with the OPTN. There's no OPTN overseeing UNOS. It's the same board of directors. There was, and so what you'd say is that that's a conflict. They have a conflict of interest. How can the boss be the same person as the person receiving the contract? But that's how it's been. So with the contentious nature of allocation changes and congressional involvement, this has basically exploded, and there have been calls for reform. HHS, but specifically HRSA, has been under a lot of pressure to make changes in the system. So in March of 23, HRSA announced the OPTN Modernization Initiative. In July of 23, Congress passed a policy act that allowed for the transplant network to be broken up. So instead of UNOS having the contracts for all the parts, now HRSA is able to get multiple contracts. And so the idea has been that how can UNOS be best positioned to take care of IT? Their IT system, everybody admits, is antiquated, not good. How can they do transportation? How can they be like Amazon Prime, figuring out how to, we have companies that are much better positioned to think about how you allocate and how you handle transportation, data management, et cetera. So just this past March, HRSA announced intention to create a corporation separate from UNOS that would house the OPTN separately from the companies that carry out allocation. So that's March. May, this past May, HRSA issued the final contract solicitations. Right now, this is calling for a contractor to support the board, the OPTN board, and up to 5 separate contractors to carry out the OPTN functions, like DonorNet, like data management, like analytics, like transportation. So the new OPTN board and committees is called INVEST. And these board members are supposedly, tentatively supposed to be elected by OPTN members, which are our transplant centers, OPOs, and HLA labs. And there will be a OPTN board support contractor to look after the board. Now, the operations contractors like DonorNet, like data management, like transportation, will report separately and solely to HRSA. So you've got HRSA as a government agent is going to oversee those contractors. So INVEST, what's INVEST? INVEST is called the Independent Network of Volunteers for Equitable and Safe Transplant, INVEST. That's going to be our new UNOS for the OPTN. And the sole purpose is to serve as a board of directors for the OPTN. This will be a have policy-making authority, but it's limited to organ allocation policies and member oversight, basically committees. So the previous OPTN board, which was the same as the UNOS board, is the current OPTN board. The bylaws were split into bylaws and policies, but what's going to happen? So the INVEST is going to operate as an OPTN board, define the roles and responsibilities. The secretary of HHS will have a special election to replace the current board at the secretary's discretion. So who's going to be that board? Nobody knows. Who's going to be nominated to be on the board of directors? Could be similar individuals who are currently on the board, but it might not be. The HRSA and INVEST will meet quarterly. They'll review the operational support the board receives. The idea is to have enhanced collaboration, to work collaboratively to implement applicable laws. So what's going to happen next? So there's going to be an election or selection, I should say, presumably by HRSA, of an interim OPTN executive director. Nobody knows who that'll be. There'll be a board support contract this fall. There'll be a new permanent OPTN executive director. There'll be a new process for special elections for OPTN board members. In the past, there would be OPTN board members from each of the 11 regions and elected, and secretary, treasurer, et cetera, for the OPTN. There would be patient members. 25% of the board had to be patients or living donor, some connection to transplantation. It's not clear how that's going to play out. So what are the known unknowns in this process? So what's going to be the influence of the clinical transplant community under this new structure? How much involvement will transplant groups, how much involvement will ASTS have and AST in this process? Will the new structure be transparent? So when this was adopted, there was no prior discussion, there was no public comment. HRSA just said, this is how it's going to be. So how will let's say there are 5 contractors, and these can be private corporations, private entities. Who's going to coordinate these? Right now, it looks like it's going to be HRSA. It's going to be the government, which may or may not do a great job at that oversight. Having HRSA running this process, especially with all the congressional contentious actions, what role are politics going to play in all this? Probably a lot. We're going to have parts of the country where Congress is going to could play a significant role. What role, if any, will the transplant community have in determining who the INVEST board of directors are when there's a special election? Totally unknown. I think it's fair to say that over the next several years, our entire transplant and allocation system is going to be overhauled. The role of the federal government is going to be increased, while the role of the clinical community and policymaking is likely to be reduced, maybe significantly. We don't know what the success of this overhaul will be. We don't know how well HRSA is going to be able to oversee this aspect and supervise this aspect. But for sure, change is coming. Now, a lot of us have had concerns about travel, cost, organ discards. And even within UNOS, they tried to make some changes to lessen the organ discards. In other words, make it so that instead of OPOs at 24 hours of cold time on a kidney going off the list to look for aggressive centers, that maybe that occurs at 8 hours or 6 hours. And the same for figuring out about liver discards. I think the discard rate across all organs is way too high, especially when we have the number of patients being added to wait lists and the deaths on the wait list. To me, this change is in large part a result of how things were handled with the allocation changes that took place. In other words, there's always going to be contentiousness around organ allocation change. If there's major change, there are going to be places that view it as being a winner and places that view it as being a loser. But I think the biggest issue was that many parts of the country felt that, yes, that was not favorable, but that the process wasn't conducted in an unbiased and fair way. And I think that has led to this, what we're facing now, which could be a real disaster. I think we'll just have to see how it plays. I'm going to stop there. I know this is a little bit in the weeds, but it is an important area that's going to affect us all. I'm happy to take any questions if there are any from the audience. Thank you.
the chat group open?
Yes.
Committees will remain in place or will be revised as new invest board director? What are your thoughts on?
Nobody knows. And some of this is, I don't know the number of committees in UNOS, there are a lot, like 50. And some are very tied to operational aspects. And if the operations are now going to be totally separated and they're going to be handled by these 5 independent contractors, I don't see how the committee structure will stay the same. But it's an unknown. ASTS, and I think AST separately has tried to engage HRSA. Sumaner is main administrator in HRSA who's helped to organize this. And ASTS has had several one-on-one meetings with HRSA over the last year and a few months. We started in June of 2023 to try to, 1, give advice or suggestions, and 2, find out the plans. And you can't find out the plans. And I don't know if it's, they don't want to say, HRSA, or they don't know. I think it's a bit of both. So I don't think, and for those of us who've been involved with UNOS and organ allocation for many, many years, it was you just knew the plan. You knew how the committees would go. You had terms. You could introduce new policy requests, and they worked their way. Right now, that's kind of all being thrown out the window. So we'll have to see how it will go. Yes. Marwan, can you help me with that question? What, I just didn't hear all the question.
So Live On New York, as you mentioned,
Yeah.
has been a complete disaster, and yet they're allowed to continue. And the solution has been to take liberties from Philadelphia. So do you see a world in which Philadelphia's OPO would be given the opportunity to move into New York?
So the question was, what's going to change with the OPO space? So today there are 56 OPOs spread around the country. Many have a state border. Some have more than a state border. Some are less. It's a odd configuration of geography based on where individual OPOs said, we're going to put a stake in the ground, and when that happened in 1987. And it hasn't changed much since then. Now, I didn't talk about this, but part of the a result of congressional involvement has been that OPOs are under performance pressure. And so OPOs are being judged based on 2 things. Donor, basically number of donors per population based on eligible donors. And number 2 is organ transplantation. And the OPOs are being separated into tiers based on their performance. So, and it's not a third, but they're basically 3 tiers. If you're a tier 1 OPO, which it's looking like, and this is going to be based on 2024 data. If you're a tier 1 OPO, you continue your operation. If you're a tier 3 OPO, you are going to lose your contract. If you're a tier 2, you may lose your contract. You can offer to reconfigure your OPO performance. So what's going to happen? I think 56 is going down. And a number of OPOs will be consolidated. That discussion's already starting amongst the OPOs, wanting to combine to improve they have to, or they're going to be put out of business. So OPOs are competing with each other 100%. And so the Live On New York has improved their performance significantly. I don't know if they've improved it enough. They're not tier 1. And I don't know if they'll improve it enough to get to be tier 1. But part of the fallout or part of the backlash against this whole allocation change was other places like Philadelphia saying, you can't introduce this allocation change when you've got underperforming OPO. OPO is the problem. And so Congress agreed and said they got to be put out of business if they're not performing. So we're going to see that change for sure. One of the negative fallouts of this, to me, is the broad distribution is disconnected OPOs from centers. And so what had previously been, for many areas of the country, a strong transplant center and OPO relationship has kind of gone out the window. And so OPOs, many, not all, have hired their own transplant recovery surgeons. They don't need to work with a transplant center anymore. If they don't think you're following, their plan, they go to another center further away. And I think that's been a pretty negative fallout of this whole process. But I think the OPOs are going to continue to steer a different direction from the transplant centers. Maybe some of that's good. I think a lot of that is not favorable. Yes. Yeah. And I think that is the OPOs have had a monopoly and they have not been responsive, some, in a way they should have. And from that standpoint, I think this pressure on the OPOs is very much needed. I think OPOs need, they wouldn't always consider all possible donors. If a donor wasn't suitable or their staff wasn't quite available, they would say, well, we're not going to consider, if it was single organ, we're not going to consider that. Very common. I'm not just making that up. This is common. And today, the OPOs are driven to be sure no donor is not considered. Now, part of the negative is they want organs utilized, transplanted, almost irrespective of, so the pressure to say, I don't understand why you won't accept this DCD that's 40 minutes on liver or whatever is definitely, it puts the OPO a little bit against the center. But in general, I think that effort has helped drive up organ availability. And that's been in large part why we have seen increases in transplant. Now, just to put it out there, I just learned this a couple weeks ago. The UNOS goal for 2026 is 60,000 transplants, annual transplants, which would be up a lot because I think it was over 40 last year. UNOS is changing, and a lot of us have recommended this change all along, lessening the scrutiny on outcomes at the one-year metric. So instead of how it's been, which is if you were the bottom 10%, no matter what the outcomes, you were going to get flagged as a center. That's changing. You get flagged as a center by UNOS or CMS. It is a big black eye for the center. You lose contracts. The center is the center leadership. I mean, you go from being the favored member status to, you're about to be fired. So I think that's a good move too, to say you can't say no. You can set some bottom threshold, but you can't say no matter what you do, we're going to flag the bottom 10%. Well, we don't do that in any other area of medicine, certainly not any other area of surgery. So I think that's going to be favorable too. Okay.
The issue with the opioids, and many of the opioids were offshoots of transplant centers.
Yes.
Either within centers or offshoots, and they became independent. But now clearly there is a chasm because now it's a survival game. The opioids to survive, they have to detach completely. And the organ allocation being so much broader. That brought the dynamic of organ acquisition, organ transport, distance, and accepting logistics. You may get an offer at 1 a.m. You can't make it at 1 a.m. Sorry, it won't happen. What do you see with this potential change coming up? All this dynamic being governed on organ recovery. Because when a transplant surgeon is hired by an OPO, it is neither an accrediting enterprise nor a transplant center. It's kind of in that interim space, floating space. And it's not regulated the same way. And at the same time, it impacts training and education of the future generation of surgeons. Any thoughts on that?
So when Dr. Abelshud was president of ASTS a couple of years ago, he led the charge to try to set up a credentialing system for organ recovery. And one of the odd peculiarities of transplantation, so you're doing a whatever, heart transplant, lung transplant, liver transplant, and a complex patient, and it doesn't go well. And that it happens, unfortunately, no matter even under the best of circumstances. You look at every component of that procedure. Well, guess what? For the donor organ recovery, there are essentially no regulations. So in some parts of the country, not uncommonly, you have not only not a transplant surgeon, you may have not even a physician, and maybe not even a mid-level provider. You have technicians doing organ recoveries. And there've been a lot of excellent technicians doing organ recoveries, but we have no system of saying, what are the benchmarks? How many do you need to do supervised? How do you oversee this? That's one issue. But these are dead people, and there's no regulation about taking organs out of a dead person, even though they're going into a critically ill living person. That doesn't seem right. OPOs do not want a transplant center or transplant surgeon society we met a lot of resistance. And basically this effort that Marwan started is still underway, but I don't know if we'll ever succeed, especially as the OPOs go this way and the centers go a different direction. So I don't know how we'll get past that. We try to maintain close relationships with our OPO. Centers have the right to send their own teams for any organ they accept. And we still will do that. We still will send our own teams out because unless you know who's doing the recovery, it's kind of risky to say we're just going to have somebody come in. That's one issue. Second issue is, as you point out, training is critical. How can you train your trainees if they're not doing organ recoveries, and that's a critical part of liver transplant, for example. So it's another challenge in this new system. I hope we'll get back to some oversight. I hope our trainees will stay engaged, but it's an unknown. Okay, thank you very much.